Ari will take us through the whole journey of this intervention. But just quickly to flag, there's two very interesting things that immediately came to my mind while reading this paper. It has been tested in peri-urban setting, which is as world is becoming urbanizing. So it is very interesting to see how it has been tested in this setting. And it is a very comprehensive approach where it is the detection, doorstep care, supervision, removal of access fees. So we will be really looking forward for Dr. Ari Johnson to give us the presentation. Now, to just give a brief introduction, Dr. Ari Johnson is the co-founder and CEO of MUSO. He is the assistant professor at the University of California, San Francisco. And over the past 12 years, Ari has supported MUSO to design and build this intervention, which is a very innovative way of solving the global child health crisis. He is a leading expert in this field, and we will be really looking forward to take us through this journey and also tell us how it can be replicated in other settings. So with that, I welcome Ari, and yeah, we can have the presentation.
Thank you, Sangeeta, and thank you everyone for joining today. I'm looking forward to our discussion. So, morning here in San Francisco, and this afternoon and this evening for perhaps others of you. I'm looking forward to sharing with you some of the research we've conducted together with academic collaborators from an array of different institutions, 7 different academic institutions around the world, as well as working very closely with the Malian Ministry of Health over the past decade. That research has been focused on proactive community case management. In particular, our research over the past decade has been focused on one very particular idea, very simple idea, which is that time matters. So when we think about the leading causes of maternal, newborn, and child death, each of them are exquisitely time sensitive. So the work that we're doing is organized around a very simple hypothesis, which is that if we can redesign how healthcare delivery works to optimize for speed, to reach each patient within the first moments that they're sick, with the care that is evidence-based, that we already know works, we can reach each patient quickly. Can we make significant improvements in morbidity and mortality for mothers, newborns, and children? Zooming out to a broader context here, we know that the World Health Organization and Unicef together through their joint endorsement supported the dissemination of an approach to community-based healthcare delivery called integrated community case management. Care provided by community health workers within the village or the neighborhood through an evidence-based package of prevention, counseling, diagnostics, and treatment. We know today that in sub-Saharan Africa alone, we have more than 30 countries that are in the process of scaling up care led by community health workers, and at least 28 of them doing so via this ICCM model. But when we look at the literature related to this, what we see is very interesting. We see first that there's about half a century of research supporting the components of this ICCM model, supporting the potential of ICCM and community health worker-based and led healthcare to improve morbidity and mortality for mothers, newborns, and children. However, when these programs have gone to scale, they've confronted many challenges. And we see that in an array of different studies across sub-Saharan Africa, there have been essentially low uptake, low access, and little or no mortality impact when ICCM has been scaled up across different national scale-up efforts. So why is this? our team began our journey conducting qualitative research first, mapping out by sitting beside patients what are the core barriers that are preventing or delaying patients from accessing care. The idea being that who knows better than patients themselves? What are the core elements, the core structures and factors that prevent them from getting the care that they need when they need it early? So based on research we conducted and published in Social Science and Medicine back in 2012, we were able to map out 6 core barriers that prevent or delay access to care. Those barriers being, number 1, direct costs, so user fees, point of care fees, or copays for consultation, for diagnostics, for treatment, and for other care services. There are also indirect costs, so lost work time, child care, transportation, that are involved in seeking care in many traditional and passive health systems. Third, there's the distance needed to travel to a health post or facility. Fourth, we see that even when patients arrive at those facilities, when they overcome those geographic and financial barriers, they often find providers that are not equipped with the training or the infrastructure that they need to provide the quality care that the patient seeks. And then those different factors lead to a certain level of mistrust in the healthcare system, which is borne out, at least in part, in direct experience. And finally, gender inequality is mediating and reinforcing many of these barriers and being reinforced by many of these barriers, especially in places like where I live and work in Mali, which has amongst the most extreme gender inequality in the world, and where, for example, some women and mothers are only allowed to leave the home with the permission of their husband. So this map of barriers created by patients through this qualitative research we conducted served as a blueprint. It is hypothesis generating. And we asked the question, what would happen if we took this global recommended best practice, ICCM, and built a way to deliver it that overcame these barriers? And out of that question came ProCCM, with a goal of taking this approach, ICCM, this protocol with such high impact potential, and delivering it to everyone quickly by removing those 6 core structural barriers. And there are essentially 3 core components to ProCCM. Number 1 is proactive search. So paid professionalized community health workers search door to door for patients every day. So in contrast to, for example, how I, as a medical doctor, whether in the United States or Mali, am expected to practice, I'm expected to sit and wait for patients to come to me. This is the way many or most healthcare providers care for patients around the world. We wait behind the walls of a health post, a clinic, a hospital, and provide care for the folks who walk through the door. The problem with that is that the greatest barriers that delay or prevent patients from accessing the care happen before a patient even reaches the door. So ProCCM essentially flips that norm on its head and deploys community health workers to search for patients at least 2 hours per day, 6 days per week. When they find patients, they're providing a package of care at the doorstep. The evidence-validated ICCM package. They're also searching for an array of danger signs systematically, indications that this is a patient that either has a condition that is beyond their scope of practice and beyond their skill set, or a patient who has a danger sign indicating that their life is in danger and they need care from a higher level of care within 24 hours immediately. And in those cases, they're evacuating those patients to rapid access clinics, government health centers that have been reinforced via user fee removal, via further infrastructure and human resources and training, that those health centers need to provide quality and rapid care to all comers. So these core three pieces, proactive search, doorstep care, and rapid access clinics, are the foundation of ProCCM. Within this, community health workers require intensive support and performance management. We're asking them to do some of the hardest and most important work in the world. And in order to do this, what we've found both in examining the literature and through our own practice is that even very rigorously trained community health workers are going to come out of the gate, and in their first days and months of the work, they're going to be making mistakes. They're going to be facing many challenges on that path, and so they need a lot of support in order to perform at a very high quality and to provide high quality, consistent, and rapid care to their patients. And to support this, we've embedded it within ProCCM an approach called 360 supervision. What this means is that each community health worker has a dedicated supervisor, someone who does nothing but supervise CHWs, and each CHW supervisor is responsible for, on average, 18 community health workers. Each CHW receives a 360 supervision at least once per month and receives at least 2 group supervision visits per month as well. During a 360 field supervision visit, that begins with the supervisor going out into the field without the community health worker, visiting the village and speaking directly with patients. In these interviews, the supervisor is doing 2 things. One, they're verifying the veracity, the accuracy of what's being reported by the community health worker. And 2, most importantly, they're getting feedback directly from the patient about their satisfaction with care, what things can be improved, their relationship with their community health worker. From that patient satisfaction feedback audit, the community health worker then goes to find, the supervisor then goes to find the community health worker of that village and directly shadows and observes that community health worker. Through that direct observation, they're able to assess different elements of quality of care. And then finally, that supervisor sits down and provides one-on-one feedback to their community health worker. That feedback is based on the supportive supervision validated techniques, as well as an understanding that each community health worker is going to have particular strengths and weaknesses, and there is no one-size-fits-all. When we look at our own data and also when we look at the literature, we see challenges with community health worker performance, but what we see most of all is we see a huge range of CHW performance, and there's variation not only between CHWs, but also for a given CHW, they're going to have particular areas of strength and particular areas of challenge that are unique to them. So this is a sort of precision coaching approach that tailors feedback to the community health worker and allows the supervisor to collaboratively problem solve, identifying both individual performance issues and systemic systems level challenges that affect performance, both of that CHW and across the system. to problem solve together. So these ProCCM CHWs, as I mentioned, are providing 2 hours of door-to-door home visits, searching for patients who need care every day, 6 days a week, with the goal of reaching each household at least twice per month. In rural areas where ProCCM is being tested, the ratio is 1 CHW per 700 population. In urban areas, that ratio is 1 per 1,000 population on average, where the population is more densely collected. These community health workers are providing the ICCM package, and in addition to that, per recent evidence of efficacy and feasibility, we've been able to extend this package slightly so that community health workers are both diagnosing and treating diarrheal disease, pneumonia, malnutrition, and malaria in the home for kids 0 to 59 months. They're also providing treatment and diagnosis for malaria of all ages, as well as a package of reproductive and contraceptive services. For every patient that they care for, whether they refer that patient or whether they provide care at the doorstep in the home for them, they're providing proactive follow-up visits at 24, 48, and 72 hours after that initial encounter. These visits serve both to confirm comprehension of treatment instructions and adherence to treatment, and also to assess for complications, for treatment failure, for other indications that a patient would require a higher level of care or a different course of treatment. These community health workers also are paid at least minimum wage in Mali. That is 40,000 francs CFA per month plus benefits. So that is on US dollars about $75 per month. So we've been working over the past decade or so to vet this approach, this ProCCM approach, via a series of different studies. Most recently this spring, our team and our academic colleagues, as well as our colleagues at the Mali Ministry of Health, published together a 7-year interrupted time series study looking at proactive community case management as it was implemented in one area of periurban Mali, looking at access to care as well as under 5 mortality rate. So first, looking at access to care, based on clinical records, we saw a 10-fold increase in number of patient-provider visits when you combine in-the-home visits as well as clinic visits. We also found a significant increase in early access to care with a more than doubling of early effective antimalarial treatment. That is treatment with an effective antimalarial within 24 hours of symptom onset. So far more patients were getting treated, and they were getting treated far earlier. Then we looked at under 5 mortality rate, and this is what we found. The baseline under 5 mortality rate in the area of intervention was 154 per 1,000 live births. At year 7, the rate was 7 per 1,000 live births. And that difference was statistically significant at the level of P is less than 0.0001. To put that in some context, on this slide we can see trend lines for the national under 5 mortality rate, the average for urban areas of Mali, and then for the areas of intervention. Now, let's look first at the national under 5 mortality rate. That rate we see declining consistently over the course of these years of intervention, and considerably so. That's the black line that is slowly descending. Beneath that, you see the black dotted line, which is running approximately parallel to this other black line. That line which is parallel but a bit lower, is for urban areas of Mali on average. So these include areas that are somewhat better off at the center of the capital city, the better off neighborhoods of urban Mali average together with periurban slum areas. And then the areas of intervention you see and that is in the blue dotted line and the blue dots. You see on the far left, in 2008, the baseline rate is sitting on the national under 5 mortality rate. And that was not surprising to us because this particular set of areas where the intervention was implemented were particularly vulnerable. There are areas in the shadows on the outskirts of Mali's capital city, periurban slum areas that are particularly more vulnerable than the average Malian urban neighborhood. We then see that each year after that baseline rate, the rate of under 5 mortality was significantly lower, and that from 2010 through 2015, the rate of under 5 mortality was at 28 per thousand or lower. In 2014, that rate descended to 9 per thousand live births, and then in 2015, 7 per thousand live births. To put this into some broader context, that same year, 2015, the end line of the study, the national under 5 mortality rate in Mali was 114 per thousand live births. And you can see where other countries were sitting at the same time. So 7 per thousand live births is roughly on par with where the United States under 5 mortality rate was in 2015. So not nearly as good as the rate in the UK or Iceland, for example. So this trial has a number of very important limitations to it. So a single-site trial, so that places significant limitations on the conclusions and generalizability that we can extrapolate from this study. Number two, this is a study that was not a randomized control trial. We can compare trends in the study area to national rate trends over time, but we cannot make causal inferences. We cannot attribute this dramatic change to ProCCM. In the study, the co-authors look for other potential causes, for example, changes in demographic characteristics, the population, other confounders, and that analysis was not able to attribute this change to other factors such as redness distribution in the area, other interventions, or demographic changes. And therefore, this study concluded that the most likely cause or attribution of this change in under 5 mortality was ProCCM. However, we cannot make causal conclusions based on the study design. So building off of that trial, we, together with our colleagues at the Mali Ministry of Health, academic collaborators from half a dozen different universities around the world, have launched a cluster randomized controlled trial of proactive community case management, the ProCCM trial. This trial is following 100,000 people across 137 cluster sites, now in rural Mali. In this trial, we've randomized those 100,000 people to either receive care via a community health worker who does proactive case detection, who goes door-to-door searching for patients every day and conducts home visits, or a community health worker who is stationary, who sits at a fixed health post, like many community health workers do around the world, and sees patients at that post within their village. The hypothesis we're testing is whether a community health worker who does proactive case detection can does that proactive case detection result in earlier access to treatment, and does it decrease child mortality? Does the proactive search workflow itself, isolated from the other elements of the intervention, compared to passive community health workers, does that improve under 5 mortality rate? We've also embedded within this very large trial other nested studies, taking advantage of the trial size to look at what is the impact of proactive case detection on reproductive healthcare access, maternal health outcomes, family planning outcomes, malnutrition outcomes, as well as an embedded cost effectiveness analysis. Through our own basic costing, we know that the overall cost of this package ranges from about $10 to $13 per person per year, roughly $4 per person served per year at the community level, and roughly $6 per person per year at the primary care level, which includes reinforcement of human resources, expansion of the primary care teams and infrastructure, as well as training and removal of user fees across both levels of care. So as we've been testing this approach, ProCCM, first in urban areas and now in remote rural areas of Mali through the ProCCM trial, in advance of the ProCCM trial, we launched a rural pilot site, in a site separate from the ProCCM trial sites, where we could debug and get some preliminary ideas about the adaptability of this approach to remote rural settings. And in this area, we're following 27,000 people over the course of 3 years. That pilot is still running, but some early results from that pilot are promising. We saw very dramatic change in number of home visits in the first year of that pilot. So in the year prior to ProCCM launch, there were just under 5,000 home visits conducted, there are just under 5,000 sick patient visits conducted, all of them in the clinic. In the year after ProCCM launched in this area, there were 27,000 home visits clinic visits conducted, and a total of more than 300,000 visits when you combine the home visits and clinic visits within this catchment area. So these operational research efforts are being conducted by and with the Mali Ministry of Health as part of their national effort to scale up community health workers across the country and reduce maternal, newborn, and child mortality rates, as well as moving toward universal health coverage. And as part of this operational research partnership, the government has been drawing from the lessons of this research to inform its national efforts to deploy 5,000 community health workers across the country, focused on the most vulnerable communities, with an aim of extending access to care to 3.5 million people by 2020. So this work has been done with an array of different collaborators, including colleagues at UCSF, UC Berkeley, the University of Bamako, Harvard Medical School, the London School of Hygiene and Tropical Medicine, the National Institutes of Health, Mali Ministry of Health, and Tulane, as well as most recently the University of Michigan. We also get to work with an array of operational and implementation partners in this work. Medic Mobile, Mass Design, Partners in Health, Hope Through Health, and Tistan. And the work is currently supported by an array of funding partners, primarily private philanthropy as well as some U.S. government funding. So in the years to come, what's in store? MUSA and its partners will be engaging and supporting national efforts in 2 to 3 countries over the next 5 years to deploy evidence-based community health worker-led health interventions and provide technical assistance to this. We'll be conducting further research to inform global practice, and we will be building out our capacity to provide technical assistance to those who wish to apply the lessons that we've learned from this research. So I will stop there for now. I'm really looking forward to your questions, your feedback, and your ideas as we advance this research and this work, and we think through how what we've been learning about ProCCM can be of use to the global efforts on maternal, newborn, and child survival. Thank you.